Hello, my name is Ahmad Khalis bin Nazib. I will be presenting on the outcomes of DelNido cardioplegia in adult cardiac surgery. My team members are Dr. Lim Wen Jin, and my supervisor is Mr. Abu Yamin bin Khamis. I will be presenting on behalf of Cardiothoracic Department, Hospital Pulau Pinang, Malaysia. The study was conducted in Hospital Pulau Pinang. Cardioplegia solutions remain an important component of myocardial protection. It provides a still operating field and allows the surgeon to perform their surgeries. But it is also important that ischemic injury is kept to the minimum whilst this is done. The conventional cardioplegia used in adult cardiac surgery requires infusion every 15 to 20 minutes. Matt and DelNido developed a novel single-dose blood cardioplegia intended for use in the pediatric population. And this is to address the needs of the immature cardiomyocytes, which are susceptible to calcium overload and ischemia reperfusion injury. They've had excellent outcomes so far in the pediatric population, but data of DelNido use on the aging heart is very limited. So the DelNido composition, it is 1 part blood, 4 parts crystalloid. It is diluted in the plasmalite A solution, contains mannitol, magnesium sulfate, sodium bicarbonate, potassium chloride, and also lidocaine. It contains only a trace amount of calcium, which is very different from the conventional St. Thomas solution, which contains a significant amount of calcium. Our version of DelNido cardioplegia solution is prepared by the Penang General Hospital Pharmacy Department, and it has been prepared as per protocol described by DelNido. There are some slight alterations to our solution, but the constituents are the same. We give an induction dose of 20 mL per kilo with a maximum dose of 1 liter for adults above 50 kilos. Most of the time, a single dose is enough, but if additional dosing is required, we would give half dose. And usually we anticipate additional dosing for procedures requiring a cross-clamp time of above 180 minutes. So the objective of our study is to evaluate the performance of DelNido cardioplegia and also to assess the safety of DelNido cardioplegia in adult cardiac surgery patients. This is a single-center retrospective study with data collected from January 2020 until April 2021. We only include patients above the age of 18 years old receiving DelNido cardioplegia during open heart surgery. Parameters were gathered from patient records and also perfusion sheets. The findings are as follows. These are the pre-operative characteristics. We had a total of 22 patients, with half of our patients being male and another half being female. The mean age for our patients is 51 plus minus 17 years. 11% of our patients has diabetes, 50% has hypertension, 31% has underlying arrhythmias, pre-operative arrhythmias, mainly in the form of atrial fibrillation. 9% had a history of previous stroke, and 31% had underlying chronic kidney disease defined as a creatinine clearance of less than 60. The mean Euro score for patients included in this study is 9, the lowest being 0.8%, and the highest percentage of Euro score being 45%. And this was a salvage procedure done on a patient requiring aortic valve surgery plus CABG. The mean pre-operative ejection fraction is 50 plus minus 13%. The bulk of our cases are single procedures, 59% requiring mitral valve repair or replacement, another 9% requiring aortic valve replacement. We had a total of 27% requiring combined procedure, mainly CABG plus valve, and another 5% requiring double valve replacement. Cardiopulmonary bypass data, cross-clamp time is 127 minutes, and the average CPB time is 182 minutes. As you might have noticed, this is probably slightly longer than expected for a single procedure, but these procedures are performed through a minimally invasive method. The mean cardioplegia volume is 1 liter, and the majority of our patients only require a single dose of cardioplegia. The mean lactate is 3.9, and we had 2 patients who required defibrillation after coming off bypass after releasing the cross clamp, and this constitutes 9%. They both had ventricular fibrillation. Post-operative data, our mortality was 9%, and this is an all-cause mortality. One patient is a patient with a Euro score of 45%, requiring salvage surgery, and another one is actually a patient who passed away due to infection after 30 days being in ICU. The mean number of hours of ventilation is 19 hours. Inotropic support, mean number is 20 hours. The majority of our patients are discharged within 7 to 8 days post-op, and as you can see, the post-operative ejection fraction is 51%, which is not much difference from the pre-operative ejection fraction at 50%. Post-operative limitations of our study. This is a very small study with only 22 patients included in the study. And we only have a small number of patients with ischemic heart disease. And I think this is very important because the bulk of our surgeries in adult cardiac surgery would be patients who has underlying ischemic heart disease. This is still an ongoing study, and we have included patients with ischemic heart disease in our study as well. There is an absence of control sample, so we really cannot say whether it is actually better than St. Thomas cardioplegia. But looking at the post-operative data, post-operative ejection fraction especially, I can say that the performance is, if not better, almost the same as St. Thomas cardioplegia. The mortality is actually, I think, acceptable. The 2 patients, as I've mentioned before, are patients requiring salvage surgery, and another patient passing away due to infection after 30 days of being in ICU. My conclusion about this study is that DelNido cardioplegia has promising outcomes for adult patients requiring open heart surgery. It is relatively safe, although larger studies are required to compare its outcomes to conventional cardioplegia. Thank you.